afternoon. Good afternoon, everyone. Hey, Rebecca. Hello. Good afternoon, everyone. Welcome to lunch. My name's Katie Coburn. I work at Central Health, the Travis County Healthcare District here in Austin. Central Health is the anchor for Regional Healthcare Partnership 7, also known as the region that stole Lisa Kirsch from all of you. For the first 4 years of the waiver, Lisa Kirsch guided us through the slings and arrows of healthcare transformation. And in leading the waiver team, Lisa set a tone of transparency, open communication, and partnership with us, the DSRIP providers and the anchors, as we work to set up our programs. She understood the complexity and the ambiguity of the waiver, and also what we were all really trying to do, which is to change the way care is delivered for our patients. And she understood how that would play out across all the different kinds of providers. And she established the expectation, which continues today with our DOS and with the rest of the HHSC team, that the providers and HHSC are going to work together to find solutions to complex issues. And I think that our relationship didn't have to be that open, but it is. And I want to thank Lisa for that. Thank you. Today, Lisa is a senior policy director at the Dell Medical School at the University of Texas at Austin. She conducts health policy research and analysis to support innovations in healthcare delivery and payment, including value-based care models and community health improvement. She's continuing her focus on state policy issues and expanding her expertise to federal and local policy issues as they relate to the medical school's work. So I'm sure, are all very delighted to welcome Lisa Kirsch back to her waiver family. Thank you for joining us.
Thank you, Katie. I'm very happy and humbled to be back with you all today. I love my new job, but I will say that I do miss my DSRIP family. And so thanks for the kind words, Katie. You know, I told someone the other day at Seton Hospital when I was visiting, she said she thought she maybe knew me or had heard my voice, and I said, I know where you've heard my voice. But really behind what I did is what you all do, and really the work of what our DOS called the HHSC Dream Team. So just so many people working so hard to make this happen. So I'm really, really happy to be back with you today. And what you're going to see in my presentation is that I am in a transition between the HHSC PowerPoint style and the Dell Medical School PowerPoint style. So you'll see some of my standard bullets and then some little bit more colorful slides thrown in. Because I didn't have to run it by anybody that took them out. And also you'll notice I have borrowed heavily from both my bosses. So some of this material you've seen before from Mark McClellan, Dr. Mark McClellan, who was here last year. Dean Clay Johnston was here last year. Amanda Broden, who was in Houston recently. Or maybe it was Emily Santillis. I've also stolen some of her slides. So I'll try to cover some of those quickly that other folks are also using. One of the reasons I decided to move to the Dell Medical School is that it's a brand new medical school at a Tier 1 university with a real dedication to the community of Austin, Travis County, and surrounding. And really the flexibility as a new medical school and a new provider to think, how do we want to do things differently? So they really are, my leadership really is rethinking everything, and they brought in a lot of folks that want to improve how healthcare is delivered and the health of our community. As part of our mission, we want to revolutionize how people get and stay healthy by evolving new models of person-centered, multidisciplinary care that reward value. So in our clinical enterprise, a lot of what we're driving to is value-based care rather than the old fee-for-service models. And I've been asked to speak today on alternative payment models and DSRIP. Those are two different topics, but I think the thing that ties the two of them together is value. And so I wanted to start by talking about value-based care, then talking some about the alternative payment model movement at the national and state scene, and then talk about the future of DSRIP a little bit. And you know, why focus on value-based care? Well, that's why we're all here. That's why we all do what we do, is that we're all trying to move towards that triple aim of better health, better care, and lower costs. I think the panel that just went before me, you know, says it better than anything really, which is that DSRIP has enabled a level of innovation, regional and local innovation in this state that we could not have had absent the program. And the range of things that were talked about this morning, from, you know, the data analytics being used at Parkland and Dallas to the substance use day treatment in Amarillo, the patient-centered medical homes at 11 federally qualified health centers down in South Texas, the preterm birth with gestational diabetes focus in Odessa, all of that are activities that might not have been reimbursable if somebody had insurance, if they had commercial insurance, Medicare, Medicaid. A lot of the activities and the legwork that's going on in DSRIP are things that couldn't have been funded absent having this pool of incentive money. So it's why we're here. But we're also focusing on value-based care, and these are some of my current boss, Dr. Mark McClellan's slides, because healthcare spending in the U.S. is going up. And as a percentage of total federal expenditures, it's increasing. On the state budget side, same thing. And you'll hear this from probably some colleagues, different associations during the legislative session, that we see, even in Texas, the trend where Medicaid spending, all funds, is now surpassing K through 12 spending. So it's a big deal because we serve a lot of people and it's a lot of money. But it's not easy. You know, we don't get to pick which diagnoses we have, although we can do things to try to mitigate it. But, you know, in a lot of cases, many things are out of our control. So we're looking for other ways to reduce healthcare costs. These are a couple slides I've poached from other colleagues at the medical school who talk about the fact that better health is inherently less expensive than poor health. And that's not necessarily true on an individual patient level. You know, we know there's expensive cancer treatments, there's expensive Hep C drugs. Certain things are very expensive. But if you think overall as a population, if we are healthier as a group, that is going to be less costly to our society than if we get to the levels where disease is a major burden on us and on the healthcare system. And the Dell Medical School is really thinking about value in terms of health outcomes that matter to patients and what it costs us to deliver those outcomes. And so the most powerful way to increase value is to improve outcomes in ways that reduce costs. But cost containment definitely isn't the goal, the only goal. Our goal is better health. So Therese spoke this morning about outcome measurement, and we've heard it throughout the day today, but we need to be measuring outcomes to show the value of the work that we're doing. And there's also been some talk about IT infrastructure and data exchange and connectivity. And I definitely think DSRIP has helped lay the foundation for outcomes measurement and for data exchange. And I think there are next steps that we can take in the next iteration of the waiver to do more and better of both of those. This is another slide that Mark McClellan used last year, and really talking about where is the healthcare system going in terms of future directions of high-value care. The first thing he talked about was new effective treatments, which can cost more money. But there are many things, and including many things going on in DSRIP, that are things that can potentially cost less money and deliver better outcomes. And that includes new medical technologies that innovate in how we target care, wireless and personal remote health monitoring and telemedicine, a lot of which is going on through DSRIP, lower cost methods of treatment or sites of care, a ton of which is going on in DSRIP, including things like community health workers, peer support specialists, community paramedicine, care coordination, things that aren't necessarily traditional health insurance benefits, but that we're seeing are overall leading to better health. And then non-medical strategies for health improvement, such as targeted assistance to high-risk individuals or support for accessing social and community services that prevent complications. And I like this graph, which basically shows the U.S. is in the box, in the, the marked box, but this is looking at total spending on both health and social services across a lot of developed countries. And if you look at the total spending, the U.S. is right there in line with everybody else, but the dark bar at the bottom is the healthcare expenditures. And so what you can see is that we're a little bit more out of whack in that we're spending more on healthcare and less on the social supports compared to many of the other developed countries. And I think we're starting to see a recognition of that. Certainly DISRIP, housing, food supports, transportation, is doing a lot of those kind of softer social supports, but that do benefit health. This year, CMS released the Accountable Health Communities funding opportunity that's local organizations, but it is going to be in partnership with Medicaid agencies, and I believe there were a number of applicants from Texas that is looking to do just that. If we connect people to social services that they need that are social determinants of health, can we help to reduce the healthcare costs for those folks that have the most complex conditions? So we're definitely headed there, and I think DISRIP was there a little bit ahead of the curve in Texas. One of the things that some of my colleagues at the medical school talk about a lot is that most of health is outside of the walls of our offices. What affects people's health, if you spend 15 minutes with your doctor 3 to 4 times a year, there's only so much your doctor can do to influence your health care. What you're doing, what you're eating, if you're exercising, what your stresses are, all of those things really probably have more impact on your health than the time that you spend with the healthcare system. So, so eat more fruits and vegetables if you can. I just ate some very quickly. This is another diagram that I like a lot, and I'm not going to talk about it completely, but this is some colleagues at the medical school and talking about how we're designing care for patients and families with shared conditions. And the thing that hit home to me about this is that if you look at bundled payment, it's toward the outside of this chart. It's one of the outer circles. So before you can get to bundled payment, before you can get to alternative payment methodologies, you have to have the building blocks in place on how you're delivering your care. And I do think that a lot of that is going on in DISRIP. So at the medical school, we talk about teams for integrated practice. We talk about measuring outcomes, measuring costs. Again, I think you all are doing a lot of this, which really does put you in a better position for the changing healthcare system, which is going to be more to value, is going to be more to alternative payment models. But before you jump to getting paid a bundled payment, you've got to be delivering care in a way and measuring what you're doing in a way that enables you to do that. So again, I think we have a lot of the building blocks here. And in the next panel, a number of folks are going to talk more about this, so I'm not going to go into too much detail. But for example, Wendy from the Baylor Scott and White Quality Alliance is going to be on the next panel. They've done a great job on some of their accountable care activities, so she can talk to you more from a provider perspective about how they built that out and what it took. I'm going to talk for just one slide about specifically what the Dell Medical School is working on, and then talk more broadly about alternative payment models. Like I said, we've got a lot of folks that want to shake things up a little bit in how we deliver care, want to, starting from scratch, try to deliver care in better ways. And one way we're looking at doing this is through integrated practice units, which bring together a full range of providers and support staff who address a specific disease or clinical condition. Many of you are probably familiar with this or are doing different versions of this. We're starting out with a couple of our specialty areas where we had our chairs on board early to build out some of these models. And so two of the ones that will probably go online first for us are musculoskeletal care and complex gynecology. But these are really teams. So the doctor is part of a team that has a nutritionist, a behavioral health care provider, a social worker, nurse practitioners, a care coordinator, that's really focusing on providing integrated patient-centered care driven by evidence-based protocols. And a big emphasis on tracking outcomes, tracking costs, so that we're going to be going to payers, going to employers, Medicaid, Medicaid health plans, Medicare, you name it, and saying, we think we can do this care better and at less cost for your patients, and they'll have better outcomes if you are willing to enter into arrangements with us for the models of care that we're delivering. Our 4 value propositions, and again, I think many of you are doing this: care integration, person-centeredness, health outcomes, and cost transparency. So those are 4 things that when we go to payers and patients and employers, that we're going to be telling them, this is how we want to deliver care. So I want to step back and just kind of go into the national level, what's going on with alternative payment method models, which is what I was asked to partially speak about today. You all know this. Many of you are doing them. Medicare, commercial payers, Medicaid, all moving to alternative payment models to provide higher value care. We've seen in the last number of years the Center for Medicare and Medicaid Innovation at CMS, which its whole goal is to support the development and testing of innovative health care payment and service delivery models, and it's doing that both in Medicare and Medicaid. And then more recently, the Department of Health and Human Services established the Healthcare Payment Learning and Action Network, which is a much broader group of private payers, providers, employers, state partners, consumer groups, individual consumers, with the recognition that if we're going to accelerate the movement to alternative payment models, you can't do that with just one payer. If one payer is doing something, providers probably aren't going to be that motivated to change. But if we're moving there together, there's a greater chance that our healthcare system is going to move more toward value-based care more quickly. So that's another major national initiative that's underway. And I just pulled this off of CMMI's website, but there are 192 examples of CMMI models that are being tested by providers and provider systems in Texas. Some of you, I'm sure, are testing them. Examples of those are different levels of ACOs, bundled payments for orthopedic care, for cardiac care, respiratory care. There are also, those are mostly on the Medicare side, but there are also some models that tie to Medicaid, such as Strong Start for mothers and newborns that are being done in Texas. There's an FQHC Advanced Primary Care Practice Demonstration. So just there's a lot of good work going on in Texas that ties back to the national movement towards value-based care. And I already mentioned the Accountable Health Communities grant opportunity that some of you, I'm guessing, applied for, and that'll be awarded later this year. Briefly, and I know this is a slide that HHSC has used and that others of you are familiar with, this is that the Learning Action Network has kind of established a framework for increased complexity and evolution of different alternative payment models. And I'm going to focus, column 2 here, the slide is kind of small, but category 2 is really, you might be getting rewarded for pay for reporting or for doing well on HEDIS quality measures. So you're kind of getting your regular payment, but you also are getting some add-on payments for certain quality measures. Categories 3 and 4 is where I think CMS wants to move folks to, and these are the more complex models and what I think they're referring to as the alternative payment methodologies. And examples of these, column 3 is episode-based care, so you might have a pregnancy bundle of care. And we do. I know Community Health Choice in Houston, a Medicaid managed care organization, does have a pregnancy bundle. Other managed care plans may as well that I'm not aware of, but that's one example. This would also be hip replacement, some of the things that CMS is working on the Medicare side. And then you have in that far column, the column 4, really whole patient care. This is accountable care organizations, medical homes that have population health accountability, comprehensive care for high-risk patients. So this is where I think the federal government and these groups that are working on this are hoping to drive care. And I think a lot of the work that we're doing in DSRIP, although it's very different, can help you and is helping you to be prepared for changes in how overall care is going. Briefly on the Medicare side, those of you that are hospitals know this. Medicare is rewarding and penalizing hospitals for a number of things, similar to what HHSC is doing with Medicaid, but hospital-acquired conditions, readmissions, those types of things. And one thing I want to make sure to highlight, and this was mentioned earlier as well, is MACRA. MACRA is a piece of federal legislation that hasn't gotten as much attention, for example, as the Affordable Care Act, but I do think it's going to be a sea changer in how physicians and other clinicians get reimbursed. So it's something that is really important to know about. And significantly, through MACRA, starting in 2019, and the plan is, unless they change it, that CMS would be starting to collect data in January of 2017 for this. Physicians and other clinicians are going to have 4% of their payments at risk, and then it's going to go up to 9% over the years in Medicare for how they're doing on a lot of different quality-related measures. There's 4 categories in this first small bullet, but quality, resource use, clinical practice improvement, and advancing care information. So those are the 4 things that clinicians are going to be judged on in terms of whether they might earn that 4% or lose some money from Medicare payment. But that's a big deal. 4% is a lot of money. 9% is a lot of money. And if other payers follow suit, it becomes even higher stakes for providers. One thing that I'm hoping, as I've heard some presentations on MACRA is kind of a zero-sum game nationally, but in terms of local communities, if you have a local community that is working together, that is sharing data effectively, I think all of the providers in that local area will do better under MACRA. So I do think this is an opportunity to further health information exchange in Texas. I hope people see it as that. I mean, real money is going to be on the line, and I think if we work together, we're going to fare better than if people try to go it alone. There's also a component of MACRA, so there is this MIPS, the Merit-Based Incentive Payment System, which I think most clinicians are going to fall into, but there's also another track for advanced alternative payment models that not as many practices are going to be able to qualify for, but really, these are the guys that have a more than a nominal risk for these models that they're performing. They're using certified electronic health records, and there's more upside if you're ready to do this. And so I think hopefully, again, people will look at this and say, I might want to see if I'm ready or might be able to get into some of these new models. And CMS's goal is that by 2018, 90% of the care in Medicare be through a value-based payment model. And that could include anything in columns 2 through 4 on that previous slide. But they want 50% to be in alternative payment models. So in the columns 3 or 4, episodes or whole person care. And then they also want to drive these advanced alternative payment models. So they're moving. Medicare's moving. And I think you're going to see Medicaid programs follow suit and commercial insurers as well. So I just want to talk a little bit about Texas. The 254 counties, the 1,450 district projects. Texas Medicaid does a lot, and we have 20 managed care plans. So we have a very complex, large Medicaid program with a lot of plans managing our care. We require, and Matt Ferrara will probably talk about this in the next panel, so I won't talk about it too much. We require our managed care plans to send us reports every year, not me anymore, but HHSC, on what they're doing around value-based payment. But we don't really require any minimums. We don't require certain types of models. We don't require a certain threshold like some states have done. So the plans submit these annual reports, and the reports show that they're doing a lot of good things. The reports that came in 2015 showed that at least 10 of our plans had adopted fee-for-service plus bonus payments. And that would be an example if you're paying your providers extra if they do very well on getting kids in for well child checks. At least 6 plans had adopted partial capitation with or without bonuses, such as for pregnancy or cardiac care. And at least 6 plans had adopted share savings models, such as for reducing total cost of care, pharmaceutical spending, reducing potentially preventable ED visits. So there is a lot of activity going on with the health plans and their providers at their discretion on value-based payment. Now, other states are doing a lot of different things, and some states have been more aggressive, some states have been more prescriptive. I think in Texas, you've always got to think about the Texas environment because we're a little bit different. Every state is, but just want to give some examples of what other states are doing. And I believe Shelley Silver from Arizona will be on the panel next, and she'll talk a little bit more about Arizona. But there are some states, and these are all managed care states. So these are all Medicaid managed care states. A number of states, including Tennessee, require their MCOs to implement certain models of care. So Tennessee requires MCOs to implement its patient-centered medical home model, and it also sets retrospective episode of care models that the health plans are required to implement. Arizona has a different approach. They're incentivizing their plans. They have a 1% quality withhold, but the only way you have even a shot at accessing that is if at least 20% of your payments to providers are through quality-based payment models. And they're stepping that up year over year. So an incentive there for the plans to hit that 20% so that they have a shot at the quality pool. Some states are requiring the MCOs to move toward more sophisticated approaches over the life of their contract. An example of that is the New York roadmap, where some of you are very familiar with the New York waiver. We're all sort of familiar with it. So they're saying that by 2020, they want to have 80 to 90% of their provider payments be value-based, and 35% at risk. So kind of similar to what Medicare is saying. Some states, again, Tennessee, require their managed care plans to actively participate in multi-payer different initiatives, or to launch pilot projects that receive state approval. So there's just a lot going on, and every state does it differently. I will say that Lindsay Browning from the National Association of Medicaid Directors, also on the next panel. They just did a big study on this exact topic, so she'll have more on that for you. I did want to briefly mention a couple of states that aren't on this slide, but that I think are kind of up and coming that are good to look at, that I've heard about recently. One is Massachusetts, which has a pending waiver with CMS, an 1115 waiver, and they have managed care, and they're proposing accountable care organizations. And in two of the three scenarios, it would be in partnership with their managed care organizations. So they're kind of proposing to partner managed care and accountable care. And I think that's just one of those waivers that we should probably keep an eye on in terms of where CMS might be headed. Another state that has been brought to my attention is Utah, which is doing accountable care organizations. I heard recently that as an incentive for those guys to innovate in care, they're doing rebasing only every 3 years. And I know one of the things we've heard about our plans, it's a challenge sometimes, is if they save money, it's going to affect their cap rates downward, what HHSC pays them a year or 2 years later. So it's like, how do you have the right incentives for your plans or your ACOs to be wanting to do this kind of stuff so that they get rewarded for it, and so do the providers. And again, I'm sure Lindsay will go into more detail on this, but their recent report, which is excellent, which they did together with Baylett, does highlight some key considerations for Medicaid programs that are thinking about alternative payment models that I thought I should at least mention. This takes significant resources at the state level and at other levels too. So it's a big undertaking to do, depending on what type of an alternative payment model you do. Data collection, exchange, and integrity is vital. Provider panel size and readiness is a major consideration. Who are the Texas providers? Are they ready? Are they big enough to undertake some of these initiatives? I think a lot of states said that you want to make sure you're engaging your providers very early in the planning process to make sure that it goes well, which should be obvious. And again, I mentioned this, there need to be financial incentives for both the health plans and the providers to participate if we want to drive value-based payment. And now the third part of my presentation, one of my favorite topics, Texas DSRIP. And kind of what all this might mean for Texas DSRIP, because I know it's like, okay, you're talking about, CMS, bundled payment pilots, this is DSRIP, what does this mean for us? DSRIP, I think, is wonderful. I think what you all are doing has made a great impact on low-income folks in this state, but Texans in general, our delivery systems, a lot of improvements through this unique opportunity we had to get these funds. DSRIP is an incentive program, and so we had flexibilities we wouldn't have otherwise had to develop and improve care delivery systems, and I think to move toward quality-based payment ultimately. I would be remiss, and I think this is just something that we all know, and it's really important. Ardas highlighted it earlier, but we are serving more low-income uninsured through DSRIP right now than we are Medicaid. We're serving a lot of both. But I think when local communities were given the option of picking projects that they thought would be most impactful on their community, that is a group, those million, I mean, there's more than a million, but there's a lot of low-income adults that they saw this is a group that we could get them access to care and higher quality care using this funding opportunity. So that's just a big part of Texas DSRIP, is that we're serving both Medicaid and our low-income uninsured. Now, we know going into the next phase of the waiver that CMS wants to support sustainability of effective DSRIP initiatives without the ongoing need for supplemental payments. CMS has said DSRIPs weren't intended to go forever. They were intended to help with delivery system improvement, but then to move to something else. And also, CMS goal is to increase value-based payment, including through Medicaid managed care. So, and CMS, if I'm misparaphrasing anything, jump in. But, you know, these are two things that we know are important to CMS, and really they're important to all of us. You know, we want to improve how our healthcare system works. So HHSC and you all have been working diligently at ways to further integrate DSRIP and Medicaid managed care. And there are some projects and some areas of care where there are opportunities for that, including pediatrics, maternity care. Behavioral health care is a big area of patient need and spend in Medicaid, including integration with primary care and substance use disorders. The complex needs, high-cost patients, definitely an important group. And by the way, a couple of these, the Medicaid Innovation Accelerator Program was mentioned earlier. Texas is participating in that, both for substance use and for the complex needs, high cost. So we're definitely tapping into the national resources on that. Patient-centered medical homes. So these are all areas where there may be some opportunities to align DSRIP. If there's a DSRIP project doing one of these things that's serving a lot of Medicaid patients, that could be a fit for managed care. I want to mention one in particular that's near and dear to the medical school, and is a current focus of that Learning Action Network, which is maternity care bundles. And the LAN has recognized that as an area of high importance for Medicaid. Since Medicaid's paying for more than 50% of the births in Texas, and that's probably true around the country, this is an area that we should be looking at, where if we can improve care, we can improve children's lives, reduce low birth weight babies, and reduce expenditures, both for the maternity care episode, but also very long-term for these kids that need a lot of care if they're born with very severe chronic illnesses. So I just wanted to highlight that. That Learning Action Network did put out a report on maternity care this summer that's on their website. But I just think it's an area of importance to Medicaid. And again, I mentioned Community Health Choice is already doing something like this, and I think other plans may be looking at it as well. But there are also a lot of challenges with integrating DSRIP and Medicaid managed care. And I mean, when I tell you the state, and I know you all are looking at all this, there are a lot of resources that have been devoted to further alignment wherever we can and to aligning quality strategies. But I think, you know, we all know what these are. So I'm gonna highlight them. Our financing mechanism for DSRIP is different than for managed care. We do use intergovernmental transfers for the non-federal share in DSRIP. We have the new CMS Medicaid managed care rules, and I think the state and CMS have to figure out if we are going to be integrating some of this into managed care, what does that look like given the new rules? I mentioned again that there need to be appropriate incentives for the plans and the providers to do this, and so hopefully we can keep working with the state on, you know, what improvements can be made to the program to incentivize that. A few other things. You know, I've mentioned this. DSRIP is providing all kinds of things that you normally wouldn't get paid for by probably almost any health plan. So, you know, that's been one of the wonderful things about DSRIP. And so I think as we think about integrating into managed care, we need to think about that because we have found that a lot of those services are really important. Most DSRIP projects aren't 100% Medicaid. So they're delivery system projects. They're serving some Medicaid, but they're serving some other people. So how does that work? So these are just all questions that we've all been asking ourselves. And we have certain types of district providers, such as local health departments, that maybe aren't billing Medicaid as much. They're not your traditional Medicaid providers. And the types of district projects, prevention, wellness, that maybe aren't as good a fit for, what is going on in Medicaid managed care. So there's a lot to think about. And I'm showing the map that has been discussed a lot already, but that shows that the district regions, the 20 regions are in the dark lines. And then our Medicaid managed care regions are shown by the different colors. And in some cases, they align pretty well, and in some cases, they don't align quite as well. So that's just an added complexity when you talk about integration. But HHSC is doing a lot. They're doing many, many things to try to further integration. And our DOS talked about some of this. I won't repeat it, but I think they're encouraging that collaboration between plans and district. They're looking at prototype models for collaboration. They're looking at Medicaid policies to see what may be barriers. So there are many things that HHSC is doing, and I think they will be working with CMS in the coming year on overcoming barriers both at the federal, state level on integration. And I'm not going to read through this whole slide. This is an HHSC slide that I've co-opted on what can district providers do. But I just want to focus on one thing. And Robert Wells from Superior Health Plan will be on this afternoon's panel. He's trying to make some of this happen. The fifth bullet down here, making that business case to managed care plans. District has been different. It's been an incentive payment. That's allowed a lot of flexibility and variability, and I think it's been wonderful. But when you get in front of a managed care plan and you're asking them to pay you differently for care, it really gets down to making that business case and having the data. What outcomes are you achieving? Is this gonna, reduce hospitalizations for people with serious mental illness, that are their members? So really just can't highlight enough that, and I think a lot of the technical assistance at this summit's going to be around some of this. There's also a panel tomorrow afternoon that's going to have a number of health plan representatives and association representatives, so hopefully further discussion of that and what kind of things are important to them. And of course, for the health plans, we're all, HHSC's asked them to reach out to the district projects in their area, is encouraging them to develop and implement these models. Encouraging the sharing of data, health information technology with providers, and participation in health information exchange, which I think will be, increasingly important. So where we are now in this kind of 15 months is that my understanding is that HHSC is going to be continuing to focus on aligning their various Medicaid quality initiatives and having a glide path for, as feasible, integrating certain district activities into Medicaid managed care. My guess is that initially, based on the financing, some of that might need to be standalone programs similar to the Network Access Improvement Program, at least at the outset, and really allowing more structured time for the managed care plans and the district providers to better assess the value of the initiatives in order to further embed them in our day-to-day Medicaid business. I believe there's a lot of good coming out of district, but I don't know. I think because of the variability, we need to be better able to quantify that and make the case, both to the health plans. And I think there's ways to strengthen the program in the next extension that would allow more of that to happen. And then, what are other ways to increase value in district given where we are and where we want to go? This is just Lisa Kirsch's 2 cents, and I know everybody has their own 2 cents, so I'm not going to be too specific because I know a lot of folks are kicking around ideas for the future of the waiver and what next steps might look like. But I think my recommendation would be that HHSC should request to continue to use district to really focus on further improving systems of care for Medicaid and the low-income uninsured. I think we have a good foundation with the regional healthcare partnership structure to do that. And the district has been a critical source of funds to improve access to care and quality of care. So if we build on what we've learned, we could further strengthen the programs in ways that I think CMS would like, and our local funders who are supporting the non-federal share also would support. And to do that, how you know, hopefully district will continue. Hopefully it won't get phased down at the terms and conditions that will be, if nothing else gets negotiated. How do we evolve from our current district projects to a more coordinated care delivery system? I think we've seen a lot of great things in district where if you said to somebody, what are the types of things that are going on in district that you think are the most effective or that you would, you know, have made the most impact in your community? I mean, we've heard about some of them today, and I still think local and regional flexibility is very important. But, you know, focusing on care in the community, population health, social determinants of health, we've seen that that is going a long way in district. Care coordinations for those with the most complex needs. I mean, that's something that we need for Medicaid and we need it for the low-income uninsured. We need to improve our data collection, reporting, analysis, and exchange. Rural, urban, you know, various provider types. I think a lot of strides have been made, but I think Texas has a long way to go in that. And I think it will help us for MACRA. So I'm just going to make that pitch again. Data exchange. Better measurement of program outcomes. I mean, it's great to see what HHSC presented this morning. We're starting to see some good data, but how can we further define that or maybe standardize it or have some common state outcomes, something that when CMS looks at District Texas and when anybody looks at District Texas, they can say, you know, they're focusing on these key areas and they're moving the needle on improving health and healthcare in these areas. Increasing use of alternative payment methodologies for providers, we definitely need to go there. And I think there's opportunities both on the Medicaid side and on the low-income uninsured side. I think some of the local payers that are the counties and others that are funding care for the low-income uninsured are interested in moving to higher value models of care. And then, of course, in Texas, you know, we always have that cost sharing personal accountability, which I think is built into some of the district work that's going on already, but Texas kind of has a fierce sense of independence. And so just continuing to work with our programs to, you know, to bring people into their care and so that folks take ownership of their care as well. And I understand, we know the New York waiver, we know the California waiver. I think there's some things in there that are worth looking at in terms of things that might be a good fit modified for Texas. I hear there are these other waivers that CMS is looking at now that we probably also should be looking at. Massachusetts, Washington, and Rhode Island. So those are kind of the three that are in the hopper right now that they're looking at. It's up on their website, you know. So I just think looking at, you know, where are different states going? What are concepts that CMS has approved in recent waivers that we might want to look at that are also a good fit for Texas? We have to Texasize them somehow. But, you know, that would work for us given our diversity and the size of our state and where we are. So that's my pitch. I think the best is ahead of us, and I've been glad to be a part of it with you so far, and I look forward to seeing what comes next. And hopefully you made it. Have you made it to your dessert? I thought if I could get you to your dessert, you'd get a little sugar rush, and fewer of you would fall asleep as I droned on. I don't know if there are any questions. If there are, I'm happy to take them. Otherwise, I think I'm going to highlight a couple of regions. Should I go ahead and do that? Okay. So I'm going to briefly talk about a couple more of the regions, like our DOS did this morning, and just showcase a couple of projects. And I'm going to move just a little bit closer because I don't have this in hard copy. The first one is Regional Healthcare Partnership 4, which is anchored Corpus Christi, the Nueces County Hospital District area. But it's a big region along the coast. I guess, you know, Texas has a lot of southeasts, but kind of north of the valley. South of here. It's 18 semi-urban and rural counties, diverse race and ethnicity, low median income, limited education, high poverty rates, and high uninsured. And you'll hear some of these themes for a lot of our regions. high needs areas. All of these counties are partially or fully medically underserved with the shortage of primary care specialists, behavioral health and dental professionals, high chronic disease, limited public transportation, and emergency medical services. And the project that we're highlighting in Region 4 is the City of Corpus Christi Nueces County Public Health District, which is partnering with their Diabetes Community Coalition of the Coastal Bend to implement a comprehensive system to include electronic medical records, health information exchange, and coordinated care records in key clinics and programs to create a disease management registry for Nueces County. So obviously something that's a big need in this community, and this is a tool that is helping them to manage diabetes there. They have reported improving HbA1c from a baseline of 51% and change to 38% in performance year 1. So that's a pretty drastic change. And I don't know where the folks from the Nueces County Public Health District are. Are you here? I'm sure you are. Maybe? Oh, way back in the corner. To make it. Okay. And I see you now, Linda. So we'll let them know that, that we were glad to highlight their project on helping to control diabetes in that part of the state. And the second one that I'm going to highlight, which I have in my new role at the Del Medical School, I'm getting to see more of the local district work that's going on here in the Austin and surrounding area. That's one of the perks of my new job, is that I'm able to get out a little bit more. So Regional Healthcare Partnership 7 is 6 counties: Bastrop, Caldwell, Fayette, Hayes, Lee, and Travis, including urban and rural areas. The region's population is growing significantly in every county and is increasingly diverse. And the project that we're highlighting from RHP 7 is, and this is one I've gotten to visit, with very dedicated folks. The Community Care Collaborative has expanded its community health paramedic program, and there's a lot of these health paramedic programs going on through DISIP around the state, to provide short-term case management and patient navigation services to low-income Travis County residents with multiple chronic conditions and frequent ED utilization. So these are folks who keep calling EMS to go to the ED, but what they really need is help getting their meds, or food support, or something else, maybe connection to other community services, which will serve them better than going repeatedly to the emergency department. This program has exceeded its demonstration year 4 goal of serving additional individuals through the program, with 511 individuals served. And I know these guys are here. I'm sure they are. Community Care Collaborative, yes. Thank you. So I have no idea where we are on time. Are we? We're good on time? Okay. All right, so enjoy the rest of your lunch, and then somebody will come up here and tell you what's happening next.
You are welcome to relax and continue your lunch, and we're a little bit ahead of schedule, so you actually have until 1:30 until we get together again. But I think at some point, and Rebecca can come up and tell me if I'm wrong, but that I think at 1:15 they'll probably want us to leave so they can come and clean up the rest of the lunch. But don't hurry, you got a few minutes, and just relax and finish your lunch.